Good afternoon. Welcome to this afternoon session on drug safety and diabetes. I'm really excited for the presentations that we have coming. My name is Christian Hamp. I work for Regeneron Pharmaceuticals, and I'm co-moderating this session with Almut Winterstein. You want to introduce yourself? Otherwise, I can. She is a professor at the University of Florida. Our first speaker is Hwa-Young Ko from Korea. Would you like to come up?
Good afternoon. My name is Hwa-Young Ko, and I'm currently a PhD student at Sungkyunkwan University in South Korea. I'd like to express my gratitude to all of you for attending this seminar. And today I'll be presenting my research entitled Sodium Glucose Co-Transporter 2 Inhibitors and Risk of Fractures Among Postmenopausal Women with Type 2 Diabetes. This research was funded by the Ministry of Food and Drug Safety in South Korea. Postmenopausal women are at high risk of fractures due to declining estrogen levels that disrupt the homeostasis of bone metabolism. If these individuals also had type 2 diabetes, risk of fractures could be exacerbated given that type 2 diabetes itself is an independent factor for fractures, which might be attributed to chronic hyperglycemia and accumulation of advanced glycation end products, subsequently leading to altered bone metabolism and skeletal fragility. Therefore, potential fracture risks should be carefully weighed when choosing an optimal pharmacological regimen for glycemic control in this vulnerable population. SGLT2 inhibitors have demonstrated substantial cardiovascular benefits across several pivotal trials, and accordingly, their usage in clinical practice is increasing. However, due to its unique glucose controlling mechanism through renal proximal tubules, SGLT2 inhibitor may also affect calcium and phosphate homeostasis to possibly pose harm to bone mineral density. This has been suggested as a potential mechanism that could increase the risk of fractures. However, no to very little data present in postmenopausal women regarding the risk of fractures associated with the SGLT2 inhibitors. Therefore, we aim to evaluate whether the use of SGLT2 inhibitor is associated with an increased risk of fractures in a population that carries a greater underlying risk of bone fragility. We conducted an active comparator new user cohort study using nationwide healthcare database obtained from National Health Insurance Service from 2013 to 2020. NHIS, as a single provider for health insurance in South Korea, contains health insurance claims data for roughly 97% of the entire Korean population, which is more than 50 million. Sociodemographic variables such as age, sex, residence, income level, eligibility status, health insurance types are included, and healthcare utilization information such as diagnosis, medical procedures, prescription, and health examination records are also available. Diagnoses are records coded according to the ICD-10's revision, and drugs are coded based on the domestic drug chemical code that is mapped to the ATC classification of WHO. Our study population consisted of patients with type 2 diabetes who had a prescription of either SGLT2 inhibitors or the comparator drug during this study period. Women aged 45 years or older were included to restrict to postmenopausal status, and we excluded patients with severe renal impairment or severe medical conditions such as history of ICU admission or diagnosis of cancer, and those who had a history of fractures within the year prior to the index date. Lastly, we excluded patients who initiated both of SGLT2 inhibitor and the active comparator drug on the same date to avoid exposure misclassification. The exposure included all ingredients covered by the National Health Insurance in Korea, and 2 active comparators were selected to construct 2 independent cohorts. In the first cohort, we compared SGLT2 inhibitor initiators with the DPP4 inhibitor initiators. And in the second cohort, we compared SGLT2 inhibitor and the GLP-1 receptor agonist initiator group. For each cohort, the index date was defined as the date of the first prescription of either SGLT2 inhibitor or a comparator drug, whichever came first. And following the as-treated approach, patients were followed from the index date until the earliest of the outcome occurrence, treatment interruption, treatment discontinuation, death, or end of the study period. And we introduced a 90-day grace period to determine treatment discontinuation. Thus, patients were considered as exposed until the 90 days after the end of the day's supply. The primary outcome was the overall fracture, comprised vertebral, hip, humerus, distal radius fractures, and secondary outcomes were the individual components of this primary composite outcome. All the outcomes were identified through diagnosis codes in the primary or secondary position. And we selected 65 covariates as potential confounders, which included cohort entry date, cohort entry year, age, Charlson Comorbidity Index, comorbidities and diabetes-related conditions, and co-medications, and proxies for health-seeking behaviors. We also evaluated laboratory test results from biannual health examination data, which included comprehensive variables such as waist circumference, body mass index, fasting blood glucose, and bone mineral density test results. And we only included laboratory test results in the sensitivity analysis. And as for the statistical analysis, we used propensity score fine stratification weighting method to control for potential confounders within each cohort. Multivariable logistic regression model was used to estimate the predicted probability of initiating SGLT2 inhibitor versus incretin-based drugs, given all baseline covariates. Patients from non-overlapping region of the propensity score distribution were trimmed to focus the estimation of the treatment effects in a population with clinical equipoise. And ASD larger than 0.1 were considered as a significant covariate imbalance in between treatment groups, and incidence rates based on the Poisson distribution were calculated, and Cook's proportional hazard models were used to estimate weighted hazard ratios and 95 confidence intervals. All the analyses were conducted independently within each cohort. And subgroup analyses were conducted to test for potential effect modification. We stratified on age, history of osteoporosis, osteoarthritis, or neurological dysfunction, and prior use of drugs that increase fracture risks. And we also examined the effect of the individual SGLT2 inhibitors associated with fractures. In all subgroup analysis, propensity scores were re-estimated, and p-value for interactions less than 0.05 was used to denote a significant heterogeneity among subgroups. A range of sensitivity analyses were also conducted for the primary outcome to assess the robustness of the main results. First, we repeated the main analysis among patients with history of surgical menopause and patients with a history of hormone replacement therapy to increase the validity of age-based definition for menopause. Secondly, we included laboratory test results as covariates for the PS model. And third, we varied the grace period to 30 or 60 days. And we adopted a more stringent outcome definition using the domestic procedural codes, which is related to conservative therapy or procedures of each fracture skeletal site to minimize outcome misclassification. And finally, to indirectly assess the presence of potential unmeasured confounding, we used two control outcomes, HCG infection for negative control outcome where a null association was expected, and hospitalization for heart failure as a positive control outcome where a lower risk with SGLT2 inhibitor was expected. Moving on to the results, these are flow charts presenting study participant selection in both cohorts. After applying exclusion criteria, about 369,000 patients were included in the first cohort, and 37,000 patients were SGLT2 inhibitor initiators, and 332,000 patients were DPP4 inhibitor initiators. For the second cohort, about 120,000 patients were included in the second cohort, and about 100,000 patients initiated SGLT2 inhibitors, and about 8,000 patients initiated GLP-1 receptor agonists. And the number of patients being trimmed was very small in the first cohort and slightly larger in the second cohort. And here are the baseline characteristics after PS weighting. In both cohorts, the exposure and comparator groups were well balanced, with ASD for all baseline covariates less than 0.1 after PS weighting. And notably, the second cohort had a higher prevalence of diabetes-related complications, a higher percentage of insulin users, and a greater number of diabetic medications being taken, indicating a generally more severe diabetic profile compared to the second cohort patients. Regarding the risk of fractures, users of SGLT2 inhibitors and DPP4 inhibitors yielded a weighted incidence rate of 1.41 and 1.81 per 100 person years, respectively, corresponding to 22% lower risk of fractures. And for the second cohort, SGLT2 inhibitors patients yielded 1.67 events per 100 person years, and GLP-1 receptor agonist patients yielded 1.92 events per 100 person years, and there was no association of increased risk of fractures. And results of subgroup analysis found no significant effect modification except for the history of osteoporosis for the second cohort and osteoarthritis for the both cohorts. And the results of sensitivity analysis were generally consistent. And yes, so the significance of this study is we generated evidence by comparing the safety, by comparing the commonly used second-line diabetic drugs in a population at more risk of fractures by constructing two independent cohorts. Additionally, through subgroup analysis considering various risk factors for fractures, we observed no increased risk of fractures, thereby building a safety profile for a broader range of groups. Nevertheless, residual confounding due to unmeasured covariates cannot be ruled out, and the number of patients using GLP-1 receptor agonists was low compared to other countries, which may limit the generalizability of our studies. To conclude, the use of SGLT2 inhibitors was not associated with an increased risk of overall fractures in a vulnerable population, and our findings may serve as important evidence for routine care, providing reassurance and helping healthcare providers with their decision-making. Thank you for your attention.
Thank you very much for your presentation. We probably have time for one brief question. If you have a question, please come up to the microphone and introduce yourself.
Hi, good afternoon. My name is Janine Ortega. I'm from Mexico, and I have a really small question. Did you take into account to do the propensity score or the sensitivity analysis, like the gynecobstetrical of the woman history, the gynecobstetric history, like number of pregnancies or breastfeeding status in previous pregnancies or in each pregnancy? Because these kind of factors of in the history of the woman are pretty associated with fracture almost and osteoporosis.
Thank you for your question. And unfortunately, the information about the history of pregnancy was not available in our data source, so we didn't conduct the kinds of analysis. We only conducted analysis such as restricting patients with a history of ovarian resection or hysterectomy, which might lead to surgical menopause, and the history of hormone replacement therapy, which is used for symptoms of menopause. Thank you.
Thank you.
All right, moving on to our next speaker, we have Solmaz Farzani from Boehringer Ingelheim. Oh, that was not good. Hang on, I went too far. Why would it pull this up? Select session. I'm a Mac person, so I'm always horrible with. I saw that here. Drug safety and diabetes. Now I only see us as moderator.
I think if you go past that,
Oh, next?
your individual.
Oh, here we go.
Yeah.
But that is the previous talk. So we need the next talk. Oh, here we go. All right. Yay. All right. Here's presenter view. And then you can just.
Thank you, Almut. Good afternoon. My name is Solmaz Farzani. I am a global process owner for real-world evidence from Boehringer Ingelheim. And today I am presenting the result of a post-authorization and safety study to assess the risk of acute pancreatitis in patients with type 2 diabetes who initiated empagliflozin compared to sulfonylureas. This was an in-house project at Boehringer Ingelheim, and my colleagues Ling Jiang and Christian Neokondo from our Real-World Evidence Center of Excellence, together with Lauriane Nasarallah from Patient Safety, supported me. We also received consultancy support from Christy Egley and Cynthia Gehrman from CROps in the design of the study, interpretation of the data, and also for the protocol and report. This study was funded by Boehringer Ingelheim and Eli Lilly Company Diabetes Alliance. Empagliflozin is an SGLT2 inhibitor, which is used broadly for the management of diabetes by reducing renal glucose reabsorption. There are a lot of studies on the association of acute pancreatitis and use of glucose-lowering medications. So this project was started to assess the risk of acute pancreatitis in the users of empagliflozin compared to the new users of sulfonylureas in type 2 diabetes patients. This was a non-interventional study using a new user cohort design, and for that we used two large US claims databases, MarketScan and Optum. So the data was used from 1st of August 2013, which was the date of launch of empagliflozin in the US, until the latest available data cut in both databases. So for Optum, it was end of March 21, and for MarketScan, it was end of September 20. The comparator group for this work was selected based on the clinical guideline recommendations for the management of type 2 diabetes and also current real-world treatment patterns for type 2 diabetes. And we conducted several feasibility analyses to see which cohort would have enough sample size for a powered analysis. And at the end, we realized that our dual therapy cohort, which was a cohort of empagliflozin on top of metformin versus sulfonylureas on top of metformin, has power for has enough sample size for a powered analysis. So here you see key inclusion and exclusion criteria in our study. We only studied adults with type 2 diabetes, and they must be new users of sulfonylureas or empagliflozin, and they must have at least 6 months continuous information in those two databases. We excluded patients with any history of acute or chronic pancreatitis or pancreatic cancer or any disease of pancreas. And also other types of diabetes were excluded, but we have other inclusion and exclusion criteria, which were not, all of them are not listed here. For the outcome, we used a validated algorithm to define acute pancreatitis cases. And this was a combination of acute pancreatitis diagnosis codes together with a history of having a serum lipase test and or an abdominal ultrasound. And then we evaluated and we compared patients in terms of having acute pancreatitis, and we calculated incidence of acute pancreatitis per 1,000 person years and 95% confidence intervals. So the main analysis was as treated, and hazard ratios together with 95% confidence intervals were estimated by Cox proportional hazard regression. We used propensity score matching to minimize confounding effects, and more than 100 variables were included in these propensity score models. We matched patients one-on-one, and we considered we used a nearest neighbor algorithm and calibers wide of equal to 0.2 of the standard deviation of the estimated propensity score were used to check for proper matching. Yeah, as said, incidence rates were calculated per 1,000 person years, and we calculated hazard ratios. And we also, at the end, after checking for heterogeneity, we did a meta-analysis of our findings into databases. So across MarketScan and Optum, we identified 72,600 new users of EMPA, and they were and we also identified 422,000 new users of sulfonylureas. Empagliflozin users were younger, but both groups, in both groups, the majority of users were male. And we also observed some imbalance in some variables before matching, but of course, after matching, we didn't see this imbalance. And the mean follow-up period for matched cohort was more than 6 months. So you see here some key baseline characteristics in MarketScan before and post matching. And it can be seen here in this table. Matching really went well, and because the sample size of our comparator was very big, we were able to find proper match for each empagliflozin user. Same was observed in Optum, and when we calculated the incidence rate of acute pancreatitis, we see that in general, we see that patients with who use empagliflozin had lower incidence rate of acute pancreatitis, and the hazard ratio in our pooled analysis was 0.88 with confidence interval of 0.76 until 1.02. So these results were consistent across different sensitivity analyses that we conducted. So in our sensitivity analysis, we used different definition for the outcome. We excluded a couple of ICD codes that for pancreatitis from our definition. We used intention to treat analysis. We excluded patients with ketoacidosis. We had a subgroup of patients with and without established cardiovascular disease, and different grace periods were used for our outcome definition. As you can see here, all were consistent, and the effect size all but in the same direction. So like all other pharmacoepidemiology research, our work was prone to some limitations like residual confoundings, misclassification, limitations related to claims databases, but acknowledging all of these limitations, at the end, we concluded that new users of empagliflozin on a background of metformin did not have an increased risk of acute pancreatitis versus patients initiating sulfonylureas on background of metformin. So these results were robust across multiple sensitivity analyses. They were consistent with prior findings, and thereby we just added this evidence to the well-established safety profile of empagliflozin. Thank you.
Thank you for your presentation. We have time for questions.
Hi, my name is Sushama. I just want to know what were the censoring reasons you used for the as treated? Did you censor for switching, discontinuation? Did you allow for any gaps? Can you talk about that?
Yeah, so the main analysis was as treated, meaning that as soon as patients stop using the drug or comparator, we just censor those. But then we allowed for, but then we checked as in our intention to treat analysis, and both results of like as treated and
No, in as treated, did you allow for gaps or did you?
yes.
How many days gaps did you allow, and did you?
Well, I can't remember the details now, but I'll be happy to
Okay.
discuss this after the talk.
Okay,
And the protocol is publicly available on NSAP website, so I'll be happy to talk about the details.
Thank you for the great presentation, Juliana. I was interested to learn a little bit more about the choice of the comparator group, and if you considered also testing the results against DPP4 inhibitors.
Yeah.
Thank you.
So thank you for this question. Actually, this was our biggest challenge because for comparative studies of SGLT2 inhibitors, normally we try to compare with a second or third line therapy like DPP4 or GLP-1 receptor agonist. But for this one, because there were a lot of studies mentioning that DPP4 inhibitors and GLP-1 receptor agonists both have risk of acute pancreatitis. We were not really, we didn't consider them fair comparators to be used in the study. But on the other hand, diabetes duration and severity is also a risk factor for acute pancreatitis. So we had to somehow use the treatment guidelines, and we tried by comparing EMPA on a background of metformin with SU on a background of metformin, we tried to mimic these two population and like reduce residual confounders.
Thank you for the presentation. I have a question regarding how you design the feasibility studies, I know you have a bigger sample size, you come across with the precision test or power analysis. How do you come across with that?
Yeah. So for our feasibility assessment, we had 3 cohorts, monotherapy cohort, where we counted the number of empagliflozin initiators and also metformin initiators, meaning that EMPA was the first antidiabetic drugs that these patients were used. And then we had dual therapy cohort of EMPA on metformin background and SU on metformin background. And then we had a triple therapy cohort. Like all different cohorts were designed based on treatment line therapy. And then we checked the sample size in Optum and MarketScan. And like at the end, we saw that only dual therapy cohort has enough sample size. So that the rest, the sample size was very, very limited. So.
Great, thank you so much.
Thank you.
Our next speaker is Wajid Al-Kabani. Oh, yeah. Or maybe it's could be on a different name. I'm not available. It says file not available. No.
It looks like her files didn't upload or they're not here.
That are these other people that are going in this room?
No,
These are
this
her
is the same
co-authors, so
group.
that's a single presentation.
You might have to go down to the speaker ready room and we'll figure that out, maybe.
Yeah, we can switch.
Yeah, we switch and
All right. Then we will just move to the next one.
Yep.
Okay. So next speaker is DeMarcus Jenny. Oh, Jenny DeMarcus.
yeah, usually we're told we shouldn't switch because
Yeah.
people might walk in and out, but I think in this case, to give you the opportunity to present, we should do the switch.
All right, so hi everyone. Thank you so much for being here today. My name is Jenny. I'm a fourth-year medical student at McGill University in Montreal. Today I'll be sharing our population-based cohort study on fluoroquinolones and the risk of severe hypoglycemia among users of sulfonylureas. So here are the disclosures. So fluoroquinolones are antibiotics that are used commonly for the treatment of bacterial infections, including pneumonia, urinary tract infections, and bone and joint infections. Their use has been associated with a variety of safety concerns, including hypoglycemia in some rare occasions. The risk of hypoglycemia could potentially become clinically relevant in populations who are already at a high baseline risk of this adverse event. For example, patients with type 2 diabetes who are using sulfonylureas, which are anti-diabetic drugs that are known to cause hypoglycemia. So the hypothesized mechanism is through a pharmacodynamic interaction where both sulfonylureas and fluoroquinolones increase insulin secretion through channel closure of pancreatic beta cells. Sulfonylureas are able to bind to the ATP-sensitive potassium channels, which then induces a channel closure of the beta cell, and this leads to an increase in insulin secretion. Fluoroquinolones are thought to act in a very similar manner, also leading to this insulin secretion through channel closure. So we thought concomitant use of both fluoroquinolones and sulfonylureas could potentially result in enhanced beta cell inhibition and therefore insulin secretion. So this raised the question, does concomitant use of fluoroquinolones and sulfonylureas further increase the risk of this already known sulfonylurea-induced hypoglycemia? So in terms of the evidence that has been shown already, we know that there's been a few case crossover studies and a cohort study that have all shown impressively strong increases in the risk of hypoglycemia, where one study had an up to 8-fold increase in the risk. However, these studies had several methodological limitations, including exposure misclassification, selection bias, confounding by indication, and time-dependent confounding. So the implications of these results for clinical practice remained unclear at the time. So with that being said, our objective was to assess whether the use of fluoroquinolones is associated with an increased risk of severe hypoglycemia compared to the use of amoxicillin in patients treated with sulfonylureas. So for this population-based cohort study, we used the CPRD, which is a primary care database representative of the UK population. It was linked to hospitalization and vital statistics data. We first created a base cohort, which included all new users of second-generation sulfonylureas. The date of first prescription of the sulfonylurea defined the base cohort entry date, and we excluded all patients who were less than 18 years of age, had less than 1 year of data recorded in the database, and any prior use of first-generation sulfonylureas, miglitinides, or insulin to ensure we really only had the new users of second-generation sulfonylureas. So out of the base cohort, we then created a study cohort, and this included all patients who are initiating fluoroquinolones or amoxicillin while already on a sulfonylurea. The study cohort entry date was the date of initiation of either antibiotic of interest. Exclusion criteria included use of fluoroquinolones or amoxicillin in the past 6 months, co-initiation of fluoroquinolone with amoxicillin at study cohort entry, and co-initiation of fluoroquinolone or amoxicillin with any other antibiotic at study cohort entry. We then matched fluoroquinolones and amoxicillin users 1 to 5 on the following 3 criteria. So first, we matched them based on the prior sulfonylurea prescriptions during their time in the base cohort. We then matched on the use of antibiotics other than fluoroquinolones or amoxicillin in the 30 days before study cohort entry. And finally, we matched on propensity scores. So for this, we included over 20 potential confounders, including demographics, anthropometrics, lifestyle variables, comorbidities, including many proxies of overall health and diabetes severity, and co-medications. And for this, we used greedy matching. We used an intention to treat exposure definition, where exposure was defined based on antibiotic use at study cohort entry. So by design, we had 2 exposure groups, the first being fluoroquinolone initiators and the second one being amoxicillin initiators. Patients were followed until occurrence of the study outcome, non-hypoglycemia related death, administrative censoring, day 30 of follow-up, or the end of the study period. And patients were allowed to contribute more than 1 episode of antibiotic use if they met both inclusion and exclusion criteria. The outcome was severe hypoglycemia, defined as hospitalization or death. So Cox proportional hazards models estimated hazard ratios with 95% confidence intervals of severe hypoglycemia in the matched cohort. The primary analysis was sulfonylureas and fluoroquinolones versus sulfonylureas and amoxicillin. And then we did secondary analyses where we stratified by demographics and glycemic control. We also performed multiple sensitivity analyses to account for 2 things. First, we wanted to account for any potential sources of bias, including information bias, selection bias, confounding, and correlated data. And second, we wanted to assess the effects of specific subgroups. So for example, in our cohort, we had a largely dominant ciprofloxacin cohort. So we wanted to restrict to only these users to see if there was any effect on that. And secondly, we also restricted to eGFR less than 60. So the GFR is a marker of renal function. And we thought that with renal function being diminished, there could be an accumulation of the 2 most commonly used fluoroquinolones, which are ciprofloxacin and levofloxacin, which are excreted by the kidneys. We thought there could be possibly an accumulation, and this may potentially lead to accumulation of products and toxicity. So for the results, our base cohort included over 325,000 patients initiating sulfonylureas, and the study cohort included over 143,000 patients initiating either a fluoroquinolone or amoxicillin. The patients contributed over 318,000 episodes of antibiotic use. Before propensity score matching, there were a few differences between the 2 groups, and after propensity score matching, the covariates were well balanced, except for prior antibiotic use, which was then included in the outcome model. So here are the results of the primary and secondary analyses. For the primary analysis, we found no increase in the risk of severe hypoglycemia when comparing users of sulfonylureas and fluoroquinolones to sulfonylureas and amoxicillin. We also found no effect modification by sex or glycemic control. However, we did see an effect modification for age. So in those aged less than 65 years, sulfonylureas and fluoroquinolones was associated with an almost 3-fold increase in the risk of hypoglycemia when compared to sulfonylureas and amoxicillin. And there was no difference in the risk in those aged above 65. So here's a forest plot depicting the results of the sensitivity analyses. We did numerous sensitivity analyses to account for potential sources of bias. The hazard ratio varied somewhat amongst the sensitivity analyses, but overall yielded findings consistent with the primary analysis. So overall, our study has several strengths, including the large sample size, which allowed us to generate relatively precise estimates. We also used many methods to combat potential confounding, including using amoxicillin as a control precipitant and by matching on propensity score. We also controlled for depletion of susceptibles by matching on prior sulfonylurea use in the base cohort. As with all cohort studies, we had a few limitations. Exposure misclassification could not be excluded, given that we did not confirm the sulfonylurea use during the 30 days of follow-up. However, sensitivity analyses with alternate maximum duration of follow-up showed consistent findings. Second, depletion of susceptibles was also possible, given that we allowed patients to contribute more than 1 episode of antibiotic use. However, again, our sensitivity analyses restricting to only 1 episode per patient showed similar results. And finally, the generalizability is unclear, given that most of our cohort, over 90%, were ciprofloxacin users. So to conclude, in our population-based cohort study of over 300,000 patients, we found that the use of fluoroquinolones was not associated with an excess risk of severe hypoglycemia when compared to use of amoxicillin among patients treated with sulfonylureas. However, a small increase in the risk cannot be excluded, and an excess risk among younger adults is also possible. Thank you.
Thank you, Jenny. We have time for a few questions.
Hello, thanks for the great presentation. This is Shahab Abtahi from Utrecht University. I actually was wondering, what was your research question exactly? So was it about the effect of fluoroquinolones on hypoglycemia, or some interacting effect, perhaps synergistic effect with sulfonylureas? Because as far as I was seeing your slides, you didn't go to see any concomitant use with other antidiabetics, like those drugs who have less are less ominous to cause hypoglycemia, or perhaps maybe you could stratify by different antidiabetics and see. I'm sure we have this data in CPRD.
Yeah, so thank you for the question. So the goal really was to look at sulfonylureas, since they're already known to cause this drug-induced hypoglycemia. We wanted to really assess the effect of an interaction, this pharmacodynamic interaction, whereby fluoroquinolones act on the beta cell in the same manner almost as sulfonylureas. So we wanted to see, does using these two drugs together lead to a higher risk of hypoglycemia in patients who are already at this higher baseline risk, the ones using sulfos. And then we did the control precipitate with amoxicillin, just because it's one of those drugs that we know doesn't cause hypoglycemia, it doesn't interact with sulfonylureas. So we just wanted, the question, I guess, was really to assess, does fluoroquinolone act in this pharmacodynamic interaction with sulfos to increase the risk? And with the past evidence that was published, we saw like they were having really impressively high risk ratios. So we wanted to see, was this reproducible?
Thanks. Thank you for your great presentation. I had like two questions.
Sure.
First is, did you get any chance to stratify by the type of sulfonylureas that they are used? Because some of them can cause more hypoglycemia, like we know, like glyburide, the first agent of the second generation, I guess, causes more hypoglycemia than the others. So did you get that chance to stratify by the type of SU that used? And the second question is, did you get a chance also like to look at how much of sulfonylureas they are, like the dose they are exposed to, or like you're just having dispensation or like a prescription of sulfonylurea was enough for you to like act that they are exposed already?
So for the first question, we did not stratify by the type of sulfonylurea. It's a good question. It's something that we could potentially do in the future, but we just don't have the numbers to go through each of the, I think there's like 4 common ones right now that are being used, and some of them, the numbers are really low. So it doesn't make sense to us to stratify them, but hopefully in the future we'll be able to do that. For the second question, in terms of dosing, so we're unable to stratify by dosing of sulfonylureas. The way that we did it was we matched based on prior sulfo use prescriptions. So if you had 0 to 5 prescriptions, you were matched with somebody else who had like the fluoroquinolone and sulfonylurea, and the amoxicillin and sulfonylurea were matched based off, let's say, 0 to 5 prescriptions, 6 to 10 prescriptions, 11 to 15, just to get them closer in that range. But unfortunately, we're not able to do it by dosing, because every person could have a different kind of dosing, and then the amount of groups we would have would be a lot. Yeah.
Thank you.
We have time for a quick question and a quick answer.
Okay. Could you comment on, Cindy Gurman, Syrups Consulting, could you comment on the effect that you saw in the younger age group, but not in the older age group? Is it because the older age group are going to primary care and the younger are going into the ER or something?
Good question. So we actually kind of looked into this a little bit more, because it was weird to us. Why are the younger people having this increased effect? And the best answer we could come up with was that the pancreatic beta cell, which is the important piece of information here where the mechanism occurs, actually degenerates the longer you have diabetes and the older you are. So for us, we thought, since this acts as a pharmacodynamic interaction where fluoroquinolones and sulfonylureas kind of do this combined effect to increase the risk, it's possible that if your pancreatic beta cells are more able to work, then there's a easier way for you to have this accumulation of then further effects, whereas those who are kind of older age, who have the less functioning of pancreatic beta cell, wouldn't have as much of an effect.
And just to make sure you rematched in your stratified analyses, right?
Yeah, everything was matched.
Okay.
Yeah.
Yeah. All right.
Thank
Great.
you.
Thank you so much. It looks like we found the slides. Yes. All right, so for those of you who walked in, we did a quick swap of the third and the fourth presentation. So Jenny just presented, and now we have Raj Akabani. Hopefully.
Oh, it's the session.
It's the third. Yeah, 1:30. Yay. Thank you.
Hi, everyone. So sorry about the tech difficulties. I hope you've had a good conference so far. So I'll be presenting a project that was part of my PhD thesis that looks at the use of insulin in type 2 diabetes and the risk of dementia. So lots of generous funding sources, most importantly, the Alzheimer's Society of Canada, but we don't have any conflict of interest to declare. So I'll start off with some background. Important background is about the link between insulin and dementia, and we'll start off with some hypotheses from pharmacology about this association, leading on to the current state of evidence from pharmacoepidemiology about the association between insulin and dementia. Spent most of the time on methods, and we'll just go over some primary results. So as you would know, type 2 diabetes and dementia are both conditions that are considered public health concerns due to increasing prevalence over the past few decades and due to significant health, social, and financial consequences. There is an evidence of an association between type 2 diabetes and dementia, both from epidemiology and pathophysiology. And in fact, there are a few complex and interconnected pathophysiology mechanisms linking diabetes to dementia, including, but not limited to, hyperglycemia, severe hypoglycemic events, hyperinsulinemia, which is what we're focusing on today, and vascular and cardio and cerebrovascular complications. So in terms of pharmacology, really the most prominent hypothesis is that hyperinsulinemia leads to downregulation of insulin receptors, leading to more competition with beta amyloid for the insulin degrading enzyme that is responsible for the clearance of insulin as well as partly beta amyloid. So this leads to the reduction in the clearance of beta amyloid. Also, exogenous insulin would lead to higher risk of hypoglycemia, which has been linked to dementia as well. But on the other hand, exogenous insulin or the use of insulin would lead to lower glycemia and potentially less macro and microvascular complications over time. So really the pharmacology evidence is conflicting. In fact, there has been some trials about the use of intranasal insulin for improving cognitive functions. Evidence from pharmacoepidemiology, on the other hand, is a little bit more obvious. So there's been 2 systematic reviews meta-analyses so far that included multiple studies, all showing a signal of harm with insulin use. So insulin is associated with a higher risk of dementia. When you look at these studies separately, we found that the biggest and most obvious issue was confounding by disease severity. So insulin was not compared to a proper comparator, sometimes even compared to metformin, sometimes in a population that's not necessarily diabetes only. So our research objective was to re-examine the association between insulin use and type 2 diabetes and the risk of dementia while minimizing confounding by disease severity. So for methods, our data source was administrative healthcare data from British Columbia, known as POP Data BC. So it's very similar to other provincial data providers throughout Canada. So for our international visitors, BC is out west, and it has more than 3 million residents, and there's universal health and drug coverage as well. So we had access to 6 databases. The registration file provided information on demographics, as well as the registration date.
The medical services plan payment provided physician claim using ICD-9 codes, up to 5 codes. We also had a hospital discharge abstract, which provided ICD-10 codes for hospitalization, up to 25 codes, as well as the admission date. We had access to PharmNet, which provided outpatient prescription dispensation and other information, including the dispensation date and day supply. We had access to vital statistics, which provided date of death, as well as a unique link to census geodata, which provided the income quintile or socioeconomic status. Okay, so for the methods, we used the new user active comparator design, and our inclusion criteria was restricted to those who have received 2 distinct non-insulin antihyperglycemic classes since diabetes diagnosis. We also made sure that they were 40 to 70 years old at baseline, and this is usually a dementia specific criteria that's seen a lot in the pharmacoepidemiology research for dementia, and that they were dementia-free at baseline. For exposure definition, it was the initiation of insulin as third-line medication versus initiating a non-insulin class as a third-line medication. So as you can see here, the infographic, we can see that the gray infographic, their background exposure was metformin and DPP-4, and they added or initiated insulin as a third line. And for the blue infographic, they were on metformin and SU, for example, and the initiation was any non-insulin class. So it could have been a GLP-1 receptor agonist, a DPP-4, and so on. The index date was the date of insulin or non-insulin initiation as a third class. So our outcome of interest was all-cause dementia, and this was captured using an algorithm that's been validated using Canadian data that requires either 1 hospitalization code, 3 physician codes, or a prescription filled for a cholinesterase inhibitor. And the validated algorithm performed relatively well. For confounding mitigation, we used 2 techniques. First, we used classic multivariable adjustment, and we included multiple demographic variables, as well as diabetes-related variables, such as diabetes duration, the presence of all the complications. Other medications as well, for example, antidepressants were important ones. And we also used inverse probability of treatment weighting, stabilized weights that were based on the high dimensional propensity score. For the primary analysis, we used the cost-specific hazards model with death as a competing risk. And also, as you would see with dementia research, sometimes cancer research as well, we used a lag period of 2 years between index date and the dementia diagnosis. Importantly, any decision that we made, whether for the exposure definition or for these lag periods, we had a sensitivity analysis where we varied these periods. So just a quick figure showing the design really well. As you can see, we requested 2 distinct non-insulin antihyperglycemic classes. There's the lag period, and these are our insulin and non-insulin users. So we had 7,863 insulin users and just above 25,000 non-insulin users. I'm not showing table 1, but you just have to trust me that IPTW did work and it led to balanced groups. As you can see, the risk estimate for all-cause dementia was the crude risk estimate was about 1.68, and it was statistically significant. Using classic multivariable adjustment, this was attenuated to 1.39, slightly statistically significant, and it was completely attenuated to 1.14 and no longer statistically significant after we used IPTW. There were no evidence of any effect modification by age, sex, or socioeconomic status when we looked for that. And these results were consistent overall with other sensitivity analysis, including changing that definition from third-line use to fourth-line use and changing that lag period and changing the age inclusion criteria. So just some limitations, as previous speakers have talked about, residual confounding despite the use of IPTW and HTPS, misclassification of the exposure. We're using dispensation data, specifically with insulin that could be tricky given the day supply, as well as misclassification of the outcome. We were also not able to look at specific subtypes of dementia, so we looked only at all-cause dementia. So just to wrap up, among individuals with type 2 diabetes previously exposed to 2 non-insulin antihyperglycemic medications, there was no significant association between insulin use and all-cause dementia. These findings do highlight the importance of adjusting for confounding, specifically confounding by disease severity, through both design and analysis and observational studies. And clinically, this overall conclusion does negate the conclusions of previous studies and provides further insight to clinicians and patients about the use of insulin in diabetes management. Thank you.
Thank you very much. We have time for questions. Please.
Thanks for the nice presentation. I was wondering, have you adjusted for the severity of diabetes in your analysis? Because I think it's really important. The two patient groups should be really different. Those who start insulin and those who start another second-line antidiabetics. And then I can imagine the first group with insulin are more sick, or for very obvious reasons, they are more prone to get dementia at the end. But despite that, you didn't see any significant results after IPTW. But yeah.
Yeah, so we didn't have a specific severity score, although there are famous diabetes severity score, including DISCO, for example. But we put in variables that I would consider proxies for diabetes severity. So we included diabetes duration. We included all the presence of several micro and macro complications. We've used, the previous medications that they were on, and so on. So there were proxies for diabetes severity, and I think to some extent they help, but we did not include a specific severity, diabetes severity score.
HbA1c values?
Sorry?
HbA1c values?
So we don't have lab measurements
Yeah.
using BC data, unfortunately. So if you were to do this in CPRD, that would be a great way to adjust for that.
Hi, thank you for your nice presentation. So my question has been asked in the context that we all know doctoral work is evolving, and you probably haven't completed all your analyses, but I'm curious, given that the medical literature indicates that at the time someone's diagnosed with dementia, Alzheimer's.
Sorry, I can't hear you very well. Sorry.
Oh, sorry. Given that the medical literature indicates that on the date someone's diagnosed with dementia, Alzheimer's, they typically have had the disease for at least 7 years. You've got the theoretical possibility of reverse causality the closer you get to the index date. Did you try other lag windows? Because 2 years seems a bit short to me for Alzheimer's.
Right, and that question always comes up, whether it's a PhD defense or a proposal. And the answer is yes. We tried multiple lag periods, and the answer is actually quite consistent up to 5 or 6 years, and that's where we start seeing a potential different conclusion. That could indicate a potential existing dementia that's not yet diagnosed, prodromal dementia. That could also have to do a lot with potentially the sample size that we were potentially losing more events. Regardless of that, you can argue that this is not necessarily a cause of dementia rather than accelerating event that led to dementia, or at least the other papers have discussed that. However, in our case, we did not find an association anyway. So yeah.
Thank you very much. Lovely presentation. Could I just ask about anticholinergic use in your 2 separate cohorts, whether or not Dr. Gray's findings of quite profound influence of anticholinergics in terms of creating a contributor to dementia, whether or not you looked at whether they were balanced in the 2 separate
Yeah, so we
groups?
did include antidepressants and anticholinergics, opioid use as well. They were actually heavily unbalanced before we started with IPTW. So if you look at table 1, you can see that. And then IPTW helped balance that. So we included a long list of antidepressants and anticholinergics and opioids and a lot of CNS drugs, yes.
So we have another minute on the issue of adjustment. So I may have not caught this. So you showed an adjusted hazard ratio and then a weighted one. So the adjusted was one where the propensity score was in the as a covariate.
Yeah, so we used classic multivariable adjustment, and it was attenuated.
Oh,
and
so
then we also used
they were individually in the model, or
sorry,
classic multivariable adjustment would suggest they all are in the model.
Yeah, so
Every
we've
single
listed
covariate?
multiple variables up to, I think, 15, 20 variables that were important, including anticholinergic, diabetes duration, the presence of microcomplications, and that helped with the analysis, of course, to mitigate some of the confounding. But obviously, IPTW was.
Do you have an explanation why it was better?
IPTW compared to classic. I think the literature about IPTW and using HTPS does show that it usually accounts for more confounding than a classic multivariable model.
Oh, you used HTPS?
Yes.
So you didn't have, okay, so there are different covariates.
Yeah, so we had the classic multivariable adjustment, and then a step up was IPTW based on HTPS.
Was there a reason why you did both, or?
Sorry?
Was there a reason why you did both?
Yeah, we just wanted to show how analysis, like we can adjust. Analysis.
That was more the PhD thesis part of trying stuff out, probably. Yeah. Okay.
Thank you.
Thank you. All right.
Next speaker is Samantha Shapiro.
Good afternoon, everyone. My name is Samantha, and I'm a PhD candidate at McGill University. And today I'll be presenting on the association between DPP-4 inhibitor use and the risk of gallbladder and bile duct disease among patients with type 2 diabetes. This research was funded by CIHR, and the authors have no relevant conflicts of interest to disclose. The incretin-based drugs for the treatment of type 2 diabetes include the GLP-1 receptor agonists and the DPP-4 inhibitors. They both exert their effects through the incretin signaling pathway to respectively upregulate GLP-1 activity and prevent GLP-1 degradation by the DPP-4 enzyme. The GLP-1RAs have been associated with multiple non-glycemic health benefits, many of which have not been associated with the DPP-4 inhibitors despite their shared pathway. However, the GLP-1RAs have also been associated with an increased risk of gallbladder and bile duct disease through an undetermined mechanism. Few laboratory or human studies have investigated the effects of DPP-4 inhibitors on the gallbladder. It remains unknown whether DPP-4 inhibitors may share the same mechanism as the GLP-1RAs and have the same association with biliary disease. A recent meta-analysis found an increased risk of biliary tract disease among patients using a DPP-4 inhibitor, both when comparing to patients using SGLT2 inhibitors and patients using placebo or non-incretin drugs. However, this analysis did not account for time until event occurrence and used non-adjudicated data extracted from adverse event reporting systems from randomized controlled trials. The quality of the evidence was accordingly deemed by the authors to be low. Contrarily, a population-based cohort study conducted by our research group in 2016 compared the use of DPP-4 inhibitors to use of 2 or more oral anti-diabetic drugs and found no evidence of an increased risk. However, our choice of a comparator drug at the time of the study was limited, and we may have had insufficient statistical power to detect an association. The objective of our study was therefore to conduct a contemporary analysis using a clinically relevant comparator drug to determine whether the use of DPP-4 inhibitors is associated with an increased risk of gallbladder and bile duct disease among patients with type 2 diabetes. We conducted the study by linking the UK CPRD Gold and ORIM, HES-APC, and ONS databases, and we used an active comparator new user design. Our study population consisted of patients registered in the CPRD who received a first ever prescription for a DPP-4 inhibitor or an SGLT2 inhibitor during the study period. We chose SGLT2 inhibitors as a comparator drug since they're also commonly used second to third line anti-hyperglycemic drugs and were not found to be associated with biliary disease. We define cohort entry as the date of the first prescription for a DPP-4 or SGLT2 inhibitor during the study period, whichever came first. At cohort entry, we excluded patients who were less than 18 years old, who had less than 1 year of medical history, who did not have a diagnosis of type 2 diabetes, who were using a combination of the study drugs or had previously used either study drug, who had a history of gallbladder or bile duct pathology, and those with certain other comorbidities and medical conditions. We used an on-treatment approach where patients were followed while continuously exposed to the study drugs, with a 30-day grace period between consecutive prescriptions. We followed patients until the first of a biliary disease diagnosis, treatment switching or discontinuation, death from any cause, end of the study period, or end of registration with the CPRD. We considered 42 potential confounders and predictors of biliary disease, which included general factors, markers of diabetes severity and management, comorbidities, and markers of general health and health-seeking behaviors. We generated propensity scores for all patients using logistic regression conditional on the previously listed covariates and used propensity score fine stratification weighting based on 50 strata of DPP-4 users to estimate the average treatment effect among the treated. We calculated incidence rates of biliary disease in both exposure groups and plotted weighted Kaplan-Meier curves to display the cumulative incidence of the outcome. We calculated the number needed to harm at 6 months and 1 year of continuous use based on the Kaplan-Meier method, and we fit crude and weighted Cox proportional hazards models to estimate the hazard ratio for biliary disease among DPP-4 inhibitor users compared to SGLT2 inhibitor users. We assessed for the presence of a duration response relationship at less than 6 months, 6 to 12 months, and greater than 12 months of continuous use. and we assessed for the presence of a dose-response relationship by converting DPP-4 prescriptions into defined daily doses and using a time-varying exposure definition to assess the relationship at less than 180, 180 to 360, and greater than 360 DDDs of DPP-4 use. We assessed whether the relationship varied by individual drug by conducting stratified analyses, and we also performed 3 subgroup analyses to assess for effect measure modification by age group, sex, and BMI group, each conducted by stratifying. To assess the robustness of our findings, we varied the 30-day grace period to 60 and 90 days, used multiple imputation to fill in missing data for certain covariates, excluded patients with a history of GLP-1 RA use in the year prior to cohort entry, conducted an ITT analysis with a maximum of 1 year of follow-up where patients were not censored upon drug switching or discontinuation, and used time-varying inverse probability of censoring weights to account for potential differences in mortality, administrative censoring, and censoring due to drug switching and discontinuation between the 2 exposure groups. After building our study population, we identified close to 150,000 DPP-4 users with a median follow-up of 0.8 years and just over 50,000 SGLT2 users with a median follow-up of 0.6 years. Our study population prior to weighting had some imbalances in age, BMI, nephropathy, insulin use, and GLP-1 RA use in the year prior to cohort entry. After weighting the SGLT2 users to resemble the DPP-4 users, standardized differences for all covariates were less than 10%. The use of DPP-4 inhibitors was associated with a 46% increase in the risk of gallbladder and bile duct disease. And weighted Kaplan-Meier curves showing the cumulative incidence of the outcome began to significantly diverge after approximately 2 months of continuous use. The number needed to harm was 948 patients at 6 months of use and 745 at 1 year of use. We observed that DPP-4 inhibitors may be associated with the highest risk of biliary disease within the first 6 months or 180 DDDs of DPP-4 use. The association between DPP-4 use and biliary disease did not vary substantially by individual drug, with similar hazard ratios found for each of the DPP-4 inhibitors. We observed no evidence of effect measure modification by age, sex, or by BMI. And our results remain consistent in all sensitivity analyses other than varying the grace period, where our point estimate was shifted towards the null as expected due to the greater exposure misclassification. Our study had multiple strengths. Use of the CPRD and its linked databases allowed for a large sample size and measurement of a broad range of covariates and confounders. The CPRD contains data on lifestyle variables such as smoking and BMI that are often missing from administrative databases. We used the active comparator new user design with a non-hierarchical exposure definition, which helped to avoid immortal time bias, allowed for the measurement of pretreatment variables, and answered a clinically relevant research question. Our study also had several limitations. There was the possibility of exposure misclassification, since the CPRD is a primary care database and does not capture drug prescriptions by specialists. However, most diabetes care and prescribing is undertaken by the primary care physician in the United Kingdom, and most prescriptions should therefore have been captured. Confounding by indication was a potential concern, since diabetes severity is an established risk factor for biliary disease, but using a comparator drug used at a similar disease stage and incorporating variables related to diabetes severity in our propensity score model should have mitigated this bias. As is the case with all observational study designs, there is a possibility of residual confounding, which we addressed by using ACNU design and by including a wide range of potential confounders in our propensity score model. And finally, to our knowledge, there is no association between SGLT2 inhibitors and biliary disease, but this has not been well studied and an association cannot be ruled out. Nevertheless, SGLT2 inhibitors remain a clinically relevant comparator. In conclusion, our study found that the use of DPP-4 inhibitors was associated with a moderately increased risk of gallbladder and bile duct disease among patients with type 2 diabetes. However, this still remained a relatively rare event, with 745 patients needing to use a DPP-4 inhibitor for 1 year to result in 1 additional case of biliary disease. Associations did not vary substantially by patient characteristic or by individual drug, and further real-world studies on this association are warranted. I would like to thank my co-authors and funding sources, and to all of the audience members, thank you very much for your attention today.
Thank you so much. We have time for questions.
Hi, Til Stürmer, UNC. Thank you for this nice presentation and state of the art. Oh, should take this off better. This is the second time in this session that I hear for the index state between the drug of interest and the comparator, whichever came first. Now, I have my hypothesis where it comes from, but I would like to hear from you where it comes from.
Essentially, so what we wanted to do was to avoid a situation in which a patient may have started, we wanted to avoid identifying the DPP-4 users first, because had a patient started an SGLT2 inhibitor during the study period, and then at a later time started a DPP-4 inhibitor, if we selected them as a DPP-4 inhibitor, that would have resulted in some immortal time between initiation of the SGLT2 inhibitor and initiation of the DPP-4 inhibitor. So that was the case that we wanted to avoid.
I don't really understand it. I mean, your exclusion criteria is to be on the drugs of interest, both the drug of interest and the comparator, and you take the first index state that meets that criteria, and that avoids any time-related issues. So why is this language that we use when we censor coming for the index state? I just don't understand it.
I'm not sure if I completely understand what you mean by the language used for censoring.
Maybe the first presenter could talk about this as well, because she mentioned the same thing. Well, both of you said for the index state, it's the drug of interest, the initiation of the drug of interest, or the initiation of the comparator, whichever came first. But the index state is the date of initiation. It has nothing to do with whichever came first.
If for example, a patient had started, my study period was from, say, 2013 to 2022. If a patient started a SGLT2 inhibitor in 2014 and a DPP-4 inhibitor in 2016.
Yes.
If I were to use a hierarchical exposure definition where I first looked for DPP-4 users, I would start that patient's follow-up in 2016 when he used a DPP-4. I wanted to avoid that because the patient started a relevant drug during the study period. I should be using that 2014 SGLT2 initiation and censoring.
It's about the washout period.
I don't think it's necessarily about the washout period, but I would be happy to discuss after the presentation.
Okay.
I mean, the immortal time issue would only come in if that was included in your follow-up, which it isn't, right? It's more a matter of, would you allow a comparator into the study who actually had active treatment before because they're switched, which you basically don't allow, right?
Okay. Okay, I think it's related to the CPRD, where you essentially have longer time periods. I mean, in the US claims data, you usually define a washout period of a year or 6 months or something. And if they don't have use of any of the drugs, we would use the initiator in 2014 on one drug and the initiator in 2016 on the other drug, if they meet inclusion criteria.
I mean, for the patients so let's say you have the database starts in 2010, and in 2005, they actually had your comparator drug. You wouldn't even know.
Right.
Right.
Well, that's why we tried to have, we excluded patients with less than a year of medical history to try to address past use and try to exclude those users.
But moving ahead, that would basically be the same thing. If you have a patient who is in your database since 2010, and in 2015, he actually happens to have your comparator drug, and you have a 1-year look back period before then where he has nothing. But in 2011, he actually had your study drug. That patient would actually qualify.
Yeah.
Technically,
Okay, yes,
right?
I see
So
what you're saying.
technically, a patient could contribute to both. I think that's where you're getting.
And then you wouldn't need that whichever came first language. But thanks. I now know what you did.
Thank you. And I would love to hear your more of your thoughts on it after the presentation.
All right, I think we need to move on. Thank you so much.
Our last speaker for today is Soko Setoguchi.
You're uploaded.
Yeah,
Should be there. Yeah,
there we go.
you're good. Thank you.
Right.
Good afternoon. So I'm presenting on behalf of Ayush Bisaria, who wasn't able to comment, and the team listed here. The disclosure is that this study is funded by NIH. And then also I wasn't able to change some animation, so you'll see some of them. And you know what I mean. So you've already heard hypoglycemia, that's the most common acute complications of people who are with diabetes, type 1, type 2, who's taking glucose lowering therapy. The public health burden is pretty high. You see the graph here, it's actually quite old data from 1999 to 2010. There's more hypoglycemia than hyperglycemia in terms of hospitalizations. As of 2018, 242,000 ED visits, and then 60,000 of them was hospitalizations. Hypoglycemia is associated with poor outcome for the patient, psychological sort of a burden, and poor QOL, quality of life, medication non-compliance, increased cardiovascular events, and mortality. So heat, you've already experienced heat this year. The July 2023, which is July last month, was the highest recorded average global temperature in the history, like 120,000 year of history. So the risk of heat is quite high. There's a suggestion that the heat might cause hypoglycemia through a mechanisms listed here. So increased cutaneous vasodilation, and then insulin uptake is increased, and then maybe a higher risk of hypoglycemia. However, there are very little study out there looking at the heat and hypoglycemia association, mostly ecological studies. Here in the older data that we're going to be looking at, there may be more at a higher risk of hypoglycemia because of their decreased thermoregulatory responses to the heat. And then patients who is taking insulin or insulin secretagogue, you already heard about sulfonylurea earlier, they might be at a higher risk of hypoglycemia, that would be at a higher risk of hypoglycemia. So the question here we're trying to address is, among the older adult over 65 age with type 1 and type 2 diabetes, or type 1 or type 2 diabetes, taking insulin or insulin secretagogue, exposure is extreme heat. And then the outcome is a hypoglycemia defined as an ED visit. And then we looked at in the summer months in 2016 and 2019. Design is a retrospective time stratified case crossover study. We use 100% Medicare Part ABD data on the virtual platform that CMS has. We linked it, we uploaded actually a temperature data into the platform called PRISM data, which is a station data collected throughout the countries and modeled using other variables into 4x4 kilometer gridded data. We linked that data to Medicare data at the zip code level. And then we looked at excess ambient heat defined as days of 99th percentile of the local warm season, May through September, as a heat index distribution ranging from 10 to 41 Celsius. We actually not only looked at the highest extreme event, 99th percentile, but we actually categorized a heat index into a different level, greater than 99, 95 to 98, so on and so forth listed here. Outcome is hypoglycemia, defined as ED visits with and without hospitalization, with primary diagnosis of hypoglycemia. This has been a modified version of previously validated definition in ICD-9. We used ICD-10. PPV was 92% in the validation study. Confounding adjustment, this is a case crossover study, so all time invariant confounders to be adjusted by design, but we also consider time varying confounding such as number of hospitalization, number of ED visits, number of outpatient visits, and number of medications. In terms of subgroups, we looked at insulin users, sulfonylurea users not taking insulin, just the sulfonylurea only. We also looked at metformin user as a more of a negative control group. This is just to show you a pretty picture of a map of the heat. So the left side is really looking at the average temperature or heat index, this case, of the 99th percentile in different regions. As you expect to see, the higher temperature is observed in the south. Here is just the average number of days of excess heat defined as 99th percentile. Again, as expected, you see more of the longer duration of heat waves in the southern regions. Starting off the not just cases of hypoglycemia, but this is in the base population that we looked at, metformin users, any insulin use, and then sulfonylurea use only. We just looked at the instance of hypoglycemia defined in the study, and then as expected, the lowest instance in metformin users only, highest in insulin use, and then in the middle in the sulfonylurea users. So as I said, we started out with a large sample, and then we came down to the number of cases, which is 32,461. In terms of the case characteristics, its distribution is as expected in terms of age and gender. And then type 1 and type 2, I think it's actually more, type 1 is more represented here in the hypoglycemia cases because they are at a higher risk of hypoglycemia. And then ED, 25,000 is ED visit only, and then 7,000 was hospitalized after ED visit. Distribution of the months and then case year is also pretty much equal throughout. So looking at the, this is the odds ratio from case crossover analysis, using the 25th and 27th percentile as the reference group, we observed increased risk of hypoglycemia as the temperature goes up, and then as the temperature goes down to the less than 25th percentile, it's a little bit lower. Wow. Okay. Sorry, I didn't know about this animation on the sulfonylurea users. Similar patterns, a little bit less pronounced than the insulin users. And then metformin users, because this is a metformin only users, we had a very small number of cases and then had a very wide confidence limits. But if you look at the point estimate, it's kind of around 1 and no kind of patterns that you see here. So in conclusion, older adults on insulin and insulin secretagogue who are exposed to heat index greater than 95th percentile had a 10 to 40% higher risk of hypoglycemia compared to when they were exposed to 25th to 27th percentile of the heat index. This association may be related to the heat-induced changes in insulin sensitivity as proposed earlier, but there's no confirmation, of course, in this epidemiologic study. Patients and providers should be aware of this potential risk of hypoglycemia at the higher temperature, take appropriate precautions. However, more studies are needed to before suggesting more concrete recommendations. And then we are kind of considering talking to our collaborators to maybe do some kind of exposure study using continuous glucose monitoring and then temperature sensing wearables to actually look at the association between the heat exposure and temperature. Also, we need to formally assess the interaction between medication use and climate on hypoglycemia because we just focused on the drug users in the study. And then incorporate additional covariates into analysis like exercise and diet if we can find the data. So this is the end of the presentation. Thank you.
We have time for a few questions.
If I can do a promotion. So this type of study, we had a symposium yesterday, kind of looking into some intersection between environmental factors, exposures, and then drug use. And also we created a SIG, special interest group called Environmental Pharmacoepidemiology. We're going to be meeting at 7 a.m. tomorrow if you're interested in.
Super timely topic. Thank you.
So, thank you for your presentation. I just have a question. Did you check how many other anti-diabetic medications used by insulin users?
No, yeah, we did. I don't have the data with me, but we know the composition of other medications. They were on, multiple other drugs. So that's why we kind of said, this is not insulin only, but it's any insulin
Yeah,
use.
and I assume that insulin users have more severity of diabetes on the diabetes duration than other groups, metformin users and
Yeah.
SU users.
I find it a very cool study, really, and as I said, very timely in particular, given the temperatures we have in Florida, for example, right now. One thing, with the case crossover designs is always the time trend that is baked in.
Yeah.
And when I was thinking, June to September, I would imagine that the temperature curve goes up in general, but metformin, of course, was a good control group, basically,
Right,
because I was worried, could there be just a time trend where you have some, more add-on on drugs and, something else that was going on in disease progression and treatment as opposed to temperature, but.
So we've been actually struggling to how to sample controls in this type of study where the time trend of the temperature exists, but also if you go bi-directional, for example, for this case, if after hypoglycemia, you would expect that the people would be reducing the dose of insulin, right, after the event. So there will be some kind of underlying changes happening if you go bi-directional.
Right.
So for this study, we just specifically chose to just go unidirectional and backwards. And of course, that is a concern. That's why we kind of brought up that metformin sort of as a group.
Hi, Suko. Sean Hennessy, University of Pennsylvania. I enjoyed the talk. So I think Abbott is a maker of a popular continuous glucose monitor. And with their app, I think they suck in all the data. I wonder if it would be possible to get the CGM data from, everybody who uses the app. I don't know whether they have zip code data or not, but.
Great idea. Yeah, thank you. And look at it the population level first before going into the individual level, small exposure study. Great, thank you.
All right.
Thank you.
Not done yet. So very quickly, where do you get the environmental data from?
So it's actually publicly available data, but we had to work with climatologists and climate data scientists to process it and to come up with a percentile. We actually compare the temperature on the location. This is daily level data from national data and then publicly available. You can download, but it's actually time consuming too because you have to download one by one for year and stuff like that. But anyway, we had to also process the data in a way that we can come up with a percentile. The tradition in the climate science is that you compare to the 30 years of the past data at the location to come up with a percentile.
Thank you.
Oh. So it's
and then also another step is to link. And then the climate data is typically longitude, latitude. So it's a 4x4 kilometer. And how to link is another sort of interesting topic. What we did is we only had a zip code of patients. And then we had to somehow, so some other groups did sort of these gridded data into zip code and then kind of mapped and weighted in a way into the area. What we did is that we chose a population centroid and then link it to the corresponding.
And then use the longitude and latitude of that centroid.
Yeah.
Fascinating. So the percentile is actually the 30-year percentile for that area,
For that area, yeah, not specifically on that zip code area, yeah.
Interesting. Okay, so that would basically mean people are used to different types of heat, and therefore it's better to compare their experiences.
Yeah, the whole idea, if you go to this type of literature, you see people using actual temperature versus percentile. The idea of using percentile is you're somehow adjusting for acclimatization.
Yeah.
Could I ask if you thought about doing 4 months in the winter?
Yes, we are actually working on that. I mean, looking at the cold side of it.
And that would the whole progression part could be, that could be a nice control for the
That's
progression
true.
concern.
Yeah.
Yeah, cool idea.
Thank you.
I think you have members for your special interest group. All right. Thank you so much. Great presentations, great comments from the audience, and enjoy the meeting.